I'm Dr. Sarah Williams, and for over 2 decades, I've worked directly with patients suffering from advanced cardiovascular disease here in the UK. What I'm about to explain challenges much of what you've been told about clogged arteries. There is one specific meal that does not merely slow plaque progression or manage symptoms, it activates biological pathways that allow plaque to reverse. I can say this with confidence because I've spent years observing diseased arteries directly, not in textbooks, but in real clinical settings. I've seen vessels hardened by calcification, narrowed by inflammation, and transformed into rigid channels incapable of healthy blood flow. Much of the advice circulating online is misleading. Arteries are not pipes, and plaque is not grease that can be flushed away with vinegar, lemon water, or supplements. Plaque is the result of a chronic immune response happening inside the vessel wall. Until you understand that mechanism, no intervention will truly work. This process involves inflammation, oxidized cholesterol, and immune cells reacting in ways most people have never been taught. The meal I'll describe later is not a trend or a cleanse. It is a targeted biological intervention designed to activate specific cellular transport systems, reduce inflammation, and prevent further damage. By the end of this explanation, you'll understand why standard advice often fails, why simply lowering cholesterol is not enough, and how the body can be supported to remove cholesterol from artery walls using science-based nutrition rather than guesswork. To understand how plaque forms, you must first understand the structure of an artery. The innermost layer, known as the endothelium, is a single layer of cells that separates the bloodstream from deeper vessel tissue. When healthy, this layer produces nitric oxide, a molecule that keeps vessels relaxed, smooth, and resistant to clot formation. However, factors such as high blood pressure, smoking, diabetes, and chronic inflammation damage these cells. Once damaged, they become sticky and permeable, allowing LDL cholesterol to slip into the vessel wall. On its own, LDL is not dangerous. The problem begins when it oxidizes. Oxidation changes LDL into a form the immune system perceives as a threat. White blood cells move into the vessel wall to deal with it, transforming into macrophages whose job is to engulf harmful material. These cells absorb the oxidized LDL but quickly become overloaded. They swell with fat and turn into what are known as foam cells, which form the earliest visible stage of atherosclerosis. These foam cells accumulate silently over years, even in young people, creating fatty streaks long before symptoms appear. The tragedy is that these immune cells are trying to protect the body, but once trapped, they cannot remove the cholesterol they've absorbed. Over time, they die, rupture, and spill inflammatory contents into the artery wall, escalating the cycle of damage and plaque growth. As foam cells continue to die and accumulate, plaque expands and begins to narrow the artery. However, narrowing itself is not the greatest danger. The real threat is plaque rupture. Plaque is not a solid mass, it is an inflamed structure with a fragile outer cap covering a core of dead cells and cholesterol debris. When that cap breaks, the contents are exposed to the bloodstream, triggering rapid clot formation. This can instantly block blood flow, causing heart attacks, strokes, or limb-threatening events. Importantly, plaques that rupture are not always the largest ones. Many dangerous plaques cause little obstruction and therefore go unnoticed by standard testing. This is why focusing solely on blockage severity often fails. Treatments such as stents may relieve symptoms, but do not address the underlying inflammatory disease. Smaller, unstable plaques are frequently left untreated, even though they pose significant risk. The goal should not be simply opening arteries, but stabilizing and reversing plaque at the cellular level. This requires removing cholesterol from foam cells and transporting it back to the liver for disposal. That process exists and is known as reverse cholesterol transport. It relies on functional HDL particles and a specific transporter protein that allows cholesterol to exit immune cells. Without activating this pathway, plaque continues to progress regardless of symptom control. Reverse cholesterol transport is the only proven mechanism for reducing plaque burden, yet in many people this process is impaired. HDL may be present but dysfunctional, unable to collect cholesterol effectively. The transporter protein responsible for ejecting cholesterol from foam cells remains underactive, allowing plaque to grow unchecked. This dysfunction cannot be corrected by surgery or medication alone. However, it can be influenced by specific dietary compounds when consumed consistently. Clinical research has shown that targeted nutritional strategies can activate this transporter, improve HDL function, and gradually reduce plaque. Cholesterol is not the only concern, though. As plaque matures, calcium begins to deposit within the artery wall. This calcification is the body's attempt to stabilize inflammation, but it results in rigid, bone-like vessels that cannot expand properly. Coronary calcium scans quantify this process and strongly predict cardiovascular risk. High calcium scores reflect advanced disease, even in people without symptoms. Standard treatment often fails to halt this progression. In real cases, individuals following low-fat diets and high-dose cholesterol-lowering medication still see calcium scores rise. This highlights the need for interventions that address inflammation, cholesterol transport, and calcium metabolism simultaneously, rather than focusing on a single marker. The meal I recommend is designed as a protocol, not a recipe. Each component serves a biological purpose and activates a specific pathway. The first element supports nitric oxide production through dietary nitrates found in certain leafy greens. These compounds are converted into nitric oxide through a bacteria-dependent process in the mouth and digestive system, improving blood flow and endothelial function. This mechanism is well established in human studies, showing rapid improvements in vascular performance. The second component provides phenolic compounds from high-quality extra virgin olive oil. These compounds reduce inflammation and stimulate the transporter responsible for reverse cholesterol transport, enabling foam cells to release stored cholesterol. Research has repeatedly shown improved cardiovascular outcomes when these oils are consumed in sufficient quantities. The third element addresses calcification through vitamin K2, which activates proteins that prevent calcium from depositing in arteries and helps redirect it to bones where it belongs. Without adequate K2, calcium accumulates in vessels, increasing stiffness and rupture risk. This nutrient has demonstrated the ability to stabilize and even reduce arterial calcification when consumed regularly. Another essential mechanism to address is oxidation. Plaque formation begins when LDL cholesterol oxidizes, triggering immune activation. Preventing oxidation interrupts the entire disease process upstream. Certain polyphenol found in whole foods bind directly to LDL particles, shielding them from oxidative damage. Among the most effective sources are compounds found in pomegranate seeds, which have been shown in clinical studies to reduce plaque thickness and improve antioxidant enzyme activity associated with HDL. These compounds not only prevent LDL oxidation, but also enhance HDL's protective functions. When combined, the components of this meal work synergistically. Nitrates restore endothelial health, olive oil phenolics activate cholesterol removal, vitamin K2 limits calcification, and polyphenol prevent oxidative injury. This approach does not rely on supplements alone or extreme restriction, but on whole foods chosen for their biological effects. Consistency is essential. This intervention must be repeated daily to maintain pathway activation. Sporadic use produces minimal benefit. When followed correctly, measurable improvements can be observed through imaging and advanced blood markers over time. Many people question the fat content of this approach, having been taught that dietary fat causes heart disease. However, decades of low-fat guidance have coincided with rising rates of obesity, diabetes, and persistent cardiovascular mortality. Fat itself is not the problem. Inflammation, oxidized lipoproteins, and dysfunctional HDL are. Reducing fat intake often lowers HDL and impairs cholesterol transport, while excess carbohydrates increase triglycerides and harmful lipoprotein particles. Diets rich in high-quality fats, particularly those found in traditional Mediterranean patterns, consistently show lower cardiovascular risk despite higher fat intake. Others worry about cost or effort. Yet the financial and physical cost of cardiovascular events far exceeds that of preventive nutrition. Preparing this meal requires minimal time and provides measurable protection. Another concern is whether medication alone is sufficient. Cholesterol-lowering drugs reduce circulating LDL, but do not activate cholesterol removal from plaque, prevent calcification, or stop oxidation. Diet and medication must work together. One without the other leaves critical mechanisms unaddressed. I share this information because too many people follow standard advice faithfully and still suffer preventable events. Medical training prioritizes procedures and prescriptions, often overlooking nutrition's role in gene regulation and cellular repair. While this knowledge exists in peer-reviewed literature, it is rarely translated into clinical practice. That gap leaves patients dependent on incomplete strategies. Understanding these mechanisms empowers you to take control of your vascular health rather than relying solely on symptom management. Monitoring progress objectively through imaging, inflammatory markers, and advanced lipid testing provides clarity on whether interventions are working. This is not about rejecting medical care, but complementing it with evidence-based nutrition. When the body is given the correct signals repeatedly, it can stabilize and even reverse disease processes once thought permanent. That is the purpose of this protocol, not promises or shortcuts, but measurable biological change. One meal, eaten consistently, activating one pathway at a time, can move arterial health in the right direction. That is the message I want to leave you with and the reason I continue sharing this work.